We also, if we're going to strategically reposition Minnesota, have to get control of our healthcare costs. There's kind of two buckets of healthcare. One is the folks who are on the publicly subsidized programs. The other is the private market. If I said to you today on the way home, go buy a television set, buy any size, color, characteristic, any features that you want, I'll pay for it, send the bill over to the governor's residence. Don't even look at the bill. Don't worry about price. Don't worry about anything else. How many of you would show up this afternoon with a 12-inch black and white at your house? Now that is fundamentally what's wrong with our healthcare system. We all get to go to the doctor, the hospital, the clinic. We are mostly unaware of the price. We're unaware of the quality of what we're receiving. Some third party, namely the government, an insurance company, or an HMO, manages and pays for the relationship. In what other walk of life do we get to go consume goods and services, be unaware of the quality, be unaware of the cost, and have a third party manage and pay for the relationship and expect that system to work? The answer is it doesn't, and it should be no mystery why that system is broken. So we also, similarly to what I just described in schools, need to move that system to a performance-based system. If you pay doctors and hospitals and clinics for volumes of procedures, what do you think you're going to get? More procedures. The measure of health isn't how the volume of the procedures that are being performed. The measure of health is, are people maintaining their health and getting better, getting healthier? That's what we should be paying for. This is a big, complex system, but similarly to the other discussion, we need to align the money we're spending to the outcomes we desire. What does that look like? Well, first of all, before we do performance pay, you have to have electronic prescriptions so we don't have a paper chase between doctors and pharmacies and patients. We should, and we've now required that in Minnesota. We've got to get everybody on electronic medical records. The idea that we're living in the year 2009 and these folks in the healthcare delivery system are running around with carts full of paper is stupid, and it's filled with errors and handwriting issues. So we're moving towards electronic medical records. Regardless of the number of payers, we should get them all to use one set of billing codes so you don't have this army of people in the back rooms of hospitals and doctors' offices and clinics all trying to figure out the rules and codes for different insurance companies, different government programs, and the like. They can use their proprietary forms, but they should have one set of billing codes. So we're moving and requiring that, and all of that together will take out 5 or 7% of the cost of the system. But beyond that, we have to say to folks, like we did with our state employees, you can go anywhere you want, but we're going to give you good information about cost and quality, and if you choose to go to a place with really bad results, that's expensive, you're going to pay more. And if you choose to go to a place with good results, that's more efficient, you'll pay less. That's what we have to do. And we have to pay providers not based on how many procedures they perform, but are you getting people healthier? Do you have better results? So, for example, in diabetes, if you have Mayo Clinic, world-class level treatment protocols applied to your diabetic population, to your patients, you can make them better, you can have them be healthier, and it saves money in the sense that you do not have all the complications from mistreated, undertreated, wrongly treated diabetes. And some of those things can be very severe and very acute, like organ transplants or like amputations. And we found in Minnesota that the percent of people who are getting world-class diabetes treatment, Mayo Clinic level diabetes patient treatment amongst the diabetic population was 6% of the patients. So we said to the providers, we will pay you more if you can get a higher and higher and higher percent of your patients on those kinds of treatment protocols. And it's working. They are getting more people on those kinds of treatment protocols. The folks are getting healthier, and the costs in the system are being contained. When we did that with our state employees, similar arrangements for a variety of things, the healthcare premium increases for the state employees 2 years ago, 0% increase, 0%. Last year, 6%. We collected too much money at 6%, so we're rebating money from last year this year in the form of debit cards that they can use for out-of-pocket expenses. And this year, the insurance premium increases for the state employees 3%. It's almost unheard of in the private market because we're starting to say we're aligning money to cost and quality. And shock, surprise of all surprises, it works. On the publicly subsidized side, the costs of those programs are bankrupting the federal government, and they're bankrupting the states, and it's bankrupting the counties. They're going up too fast. It's unsustainable. 26% a budget cycle. We can't keep up with that. It is crowding out the ability to fund other things in Minnesota. So we've proposed to slow down the rate of increase in those programs to something more sustainable, not decreasing them, but slowing down the rate of increase. That's very difficult to do because the programs serve, in many cases, either economically or from a health standpoint, challenged individuals and families. They are important programs, but they are not so important that they should be allowed to suffocate our ability to fund other things we also have to do, like K-12 education, like fund our colleges and universities, like fund our roads and bridges, and the like. So we're trying to slow that down to something more sustainable with all of the federal money that's coming in. That kind of can is being kicked down the road because the cuts I proposed or the reductions in growth that I proposed are the money's now available to avoid most of those hard decisions. But I just want to share with you that we have to change the trajectory of the growth of those programs for all the reasons that we talked about at the onset, defined